Wide complex tachycardia electrophysiological studies. Electrophysiological studies are usually only feasible for sustained monomorphic ventricular tachycardia, SMVT, since non-sustained ventricular tachycardia, NSVT, is too short to allow reliable evaluation. Polymorphic VT is invariably associated with rapid hemodynamic collapse. Fast, unstable SMVT usually can be slowed down by antiarrhythmic drugs, such as procainamide, to permit evaluation. Sustained monomorphic VT. The majority of sustained monomorphic VT are caused by reentry, involving a region of ventricular scar. Most cases are due to old myocardial infarction. Other causes include non-ischemic cardiomyopathy, surgical incisions, arrhythmogenic right ventricular dysplasia, sarcoidosis, and Chagas disease. EPS in sustained monomorphic VT. 1. Induction of tachycardia. 2. Tachycardia features. 3. Diagnostic maneuvers during tachycardia. 4. Exclusion of other arrhythmia mechanisms. Induction of tachycardia. Stimulation is done first from the right ventricular apex, then from the right ventricular outflow tract. Start with ventricular extrastimulus, VES, single, double, or triple VES, with decreasing coupling interval, increasing prematurity. If VES fails, proceed for rapid ventricular pacing, usually started at a pacing cycle length of 400 millisecond, then gradually decreasing the cycle length. Reproducibility of VT initiation. Greater than 90% of patients with clinical SMVT will have their VT inducible, regardless of the underlying pathology, except for exercise-induced VT. Tachycardia features. 1. AVVA dissociation, with more V waves than A waves. 2. Fascicular VT features. 3. His bundle potentials, H waves. This figure shows AVVA dissociation, with more V waves, seen in right ventricular apex, RVA, channel, than A waves, seen in high right atrial, HRA, channel. In fascicular VT, 2 additional waves are recorded from the left ventricle, LV, beside the V waves, the pre-Purkinje, PP, diastolic potential, and the Purkinje, P, presystolic potential. His bundle, HB, potentials, H waves, can be recorded during VT in about 80% of patients, before, during, or after the QRS, depending on the relative anterograde and retrograde conduction times. It is often difficult to determine whether the recorded HB potential is anterograde or retrograde. Differentiation. In WCT with the H wave before the V wave. An HV interval during tachycardia shorter than that during sinus rhythm suggests VT or pre-excited SVT. An HV during tachycardia equal to or longer than that during sinus rhythm suggests SVT with aberrancy or bundle branch reentry VT. Intermittent H waves. H waves can appear intermittently, typically in 2:1 or 3:2 fashion. Diagnostic maneuvers during tachycardia. 1. Ventricular extrastimulation, VES, during VT. 2. Ventricular pacing during VT. 3. Effects of drugs on VT. 4. Entrainment of tachycardia by atrial pacing. VES during VT. Single VES, or double if needed, are given starting at a coupling interval 10 to 20 milliseconds shorter than the VT cycle length, and gradually decreased by 5 to 10 millisecond. Response of VT to VES. Any of the following may occur. No effect, VES is followed by a full compensatory pause and VT not affected. Resetting, advancement of VT, with its return having the same cycle length and morphology, after a less than compensatory pause. Fusion, VES reaches the entrance of VT cycle, and at the same time allows the VT wavefront to exit the circuit, thus, a fusion beat, intermediate in morphology between VES and VT, is generated. Termination, if antidromic and orthodromic block occurs. Ventricular pacing during VT. Rapid ventricular pacing is performed during VT, at a pacing cycle length 10 to 20 milliseconds shorter than the tachycardia cycle length. Pacing cycle length is then decreased in 10 millisecond decrements until termination. Response to ventricular pacing. Any of the following may occur. Acceleration, sustained shortening of tachycardia cycle length following cessation of pacing. Transformation, occurrence of multiple distinct VT morphologies. Entrainment, overdrive pacing without termination. Paced impulse has hybrid morphology between fully paced QRS and tachycardia QRS. Termination, occurs when an impulse penetrates the circuit and blocks in both directions. Effects of drugs on VT. Class 1 antiarrhythmic agents can slow, terminate, or induce sustained monomorphic VT. Adenosine, beta blockers, verapamil, and diltiazem are ineffective for termination of post-myocardial infarction VT. Exclusion of SVT with aberrancy. If VT exhibits 1:1 VA conduction, it can mimic short RP SVT with aberration. In VT, the atrium is not part of the tachycardia circuit, and can be dissociated by atrial pacing. In SVT with aberration, HV interval during tachycardia is equal to or longer than that during sinus rhythm, in contrast to VT. Exclusion of pre-excited SVT. The HV interval is usually short or negative in both pre-excited SVT and VT. However, in VT, the atrium is not part of the tachycardia circuit, and can be dissociated by atrial pacing. Entrainment of tachycardia by atrial pacing. Entrainment of tachycardia by atrial pacing can differentiate VT from pre-excited SVT, if the response is noted after termination of pacing. In VT, the last paced A wave is conducted to the ventricles to create V wave, then VT recurs showing its V wave followed by retrograde conduction to the atria to create A wave. Thus, VVA response is noted. In pre-excited SVT, the last paced A wave is conducted to the ventricles to create V wave, followed by recurrence of the SVT with its A wave. Thus, VA response is noted. VVA response after termination of atrial pacing is diagnostic of VT. After termination of atrial pacing in pre-excited SVT, VA response occurs. Thank you.